Good afternoon, everyone, and welcome to the Maternal Health Echo brought to you by the Center for Substance Use Training and Telementoring Center, CSTAT, at Bewell, Texas, in collaboration with the Perinatal Psychiatry Access Network, or PeriPAN. My name is Brenda Macias, and I'll be facilitating our discussion today. I have just a few quick housekeeping notes before we begin. First, to help us with attendance, please enter your name, affiliation, and email into the chat. To access the chat feature, click on the speech bubble icon on the navigation bar at the bottom of your window. And if you're joining us via phone, please email your phone number and your name to cstat@uthcsa.edu. We encourage everyone to join us by video for the discussion portion in the later half of the session. But no matter how you're joining us today, we are happy that you're here to learn alongside us. We encourage you to speak, but we ask that you stay muted unless you are speaking. There's a lot of us in this space, so keeping your comments brief will allow others the chance to share as well. And finally, please note that no protected health information is allowed in either the chat or in our discussions. Our didactic today is on universal screening for behavioral health conditions in pregnant and postpartum women, and will be presented by Dr. Denis Antoine. Following that, we will have a case presented by Montrese Green. We'll start with introductions, followed by didactics, the case presentation, open discussion, and wrap up with announcements. Once again, thanks for joining us today. So we'll start with our introductions of our hub team. I'm going to start with Dr. Humphrey.
Good morning. I'm Dr. Humphrey. I'm a family nurse practitioner in Waco, Texas, and I've spent time doing inpatient and outpatient substance use disorder treatment for women, pregnant and not pregnant.
Thank you, Dr. Humphrey. Dr. Subrin?
Hi, good morning, everybody. I am Dr. Joy Subrin. I'm a doctor in behavioral health and a licensed master of social work. I am at Banner University Medical Center in Tucson, Arizona. I have done both inpatient and outpatient service and always in women's health and with a specific interest in postpartum and antepartum depression and substance use disorder in women. Happy to be here.
Thank you, Dr. Subrin. Dr. Alag? Give her just a few moments to join. And we welcome our hub team members, and we thank you for being here today. And now I'd like to turn it over to our presenter, Dr. Denis Antoine. Thank you as well for being here, and we look forward to your presentation after your introduction. Just whenever you're ready.
All right, thanks for having me. I'll put up my presentation as just talk a little bit about my background. My name is Dr. Denis Antoine. I'm a psychiatrist by training, but I'm actually now, the role for today that's most relevant is the director of what has been called the Center for Addiction and Pregnancy at Johns Hopkins Bayview in Baltimore, Maryland. So coming to you from a couple time zones away. I've gone through psychiatry training and also board certified in addiction medicine, and I've been director of inpatient and outpatient programs that have worked with individuals who've had co-occurring issues along with their substance use disorders. But obviously over the past few years since becoming director of the CAP program, integrative strategies for screening for behavioral health and perinatal care has been a big part of what I do. So very happy to be here today and looking forward to the questions. I always find those the most informative at the end. So let me just jump in, given the time. No disclosures relevant for today. And following the session, here are the objectives that I look to accomplish, many of which I think people already hold true to their practices, and I'm hoping I can be helpful to add more flavor to what people do in their day-to-day activities. But the bigger outline of that is looking into these main areas. And of course, each of these could be 2-hour conversations in and of themselves, but I wanted to make sure that we touched upon some of them relevant to the perinatal period, just to make sure that we get to the point of how do we maximize screening for behavioral health during the perinatal period. And for those who aren't aware of the Center for Addiction and Pregnancy, it has been around in different versions since 1991. And the goal, as this diagram show, is to look at different aspects of the perinatal period. Substance use and comorbid behavioral health disorders is where I focus in the Department of Psychiatry, but we also have a multidisciplinary approach, looking at it from the pediatric standpoint and obstetric standpoint to try to get a broader sense and a wider sense of what's going on with the individual, especially the dyad itself. So it's very important that we think about this model as we go through, and that's where my outline has come from in thinking through the different aspects of what might go into care. Our mission statement, I think, again, aligns with many individuals on the call to improve perinatal outcomes of women with substance use disorders and their children through a comprehensive care model, clinical research, and education. Something probably not foreign to many and very important to keep at the forefront of what we do. Within that, there have been different examinations of what that looks like. This is actually data from an article that we were able to publish a few years ago that looked at different psychosocial factors and how they played a role with adverse perinatal outcomes. After doing a retrospective analysis of over 10,000 charts over a 5-year period, we aligned with these 3 psychosocial factors to examine them to see how they came in correlation with adverse perinatal outcomes: substance use, mental illness, and interpersonal violence. Very broad, but very common within the population that we work with. And we found that even if a person did not have these psychosocial factors, there was a 21.2% chance of an adverse perinatal outcome. However, the chances went up if there were more psychosocial factors present. And it was important to note that if there was a change between the genders, or I should say in between ethnicities, Black women had a higher chance of adverse perinatal outcomes compared to other racial groups. And that's important to note because that just shows that there are different things to look for that might correlate between adverse perinatal outcomes. So very important to keep that in the forefront. Again, thinking of the pharmacology as well, screening can be difficult because things change at different levels. The pharmacology I point out here is that, as many of you know, things do change physiologically over the course of the pregnancy. That's the cardiac output, the cardiovascular system, the respiratory system. That means that the medications that we might be using or other treatments that might be given may not be as potent as those things grow. It's almost like they become more dilute. And I have to tell people that just because you're giving a medication in the first trimester, it's not going to work necessarily the same in the second or the third trimester, and you need to keep that in mind. Also, a more nuanced approach there is that the enzymes also change in certain ways over time in the pregnancy. This is a list that's not exhaustive, but it does come to show that there are different enzymes and therefore medications that might change in their function over the course of the pregnancy. The more common one that we might think of would be caffeine. And there, this is part of the reason why caffeine is avoided during pregnancy. But it also comes to the other medications that might be more prominent, such as Lamictal, lamotrigine, things that might be used for bipolar disorder. And all to show that as you use something, you might need to monitor its efficacy over the time of their pregnancy, because it may change in its potency and you might have to make adjustments to the medications. So screening for that is a first place to start. How is the treatment working? Starting there, starting straightforward is a good place to go. Beyond that, looking at the risk of different medications that are being used is very important as well. In this case, I am using a more outdated slide. I know that this is not a commonly used slide anymore, but I still see practitioners refer to this A, B, C, D, X indication, even though it is outdated. And I bring it up to show that it's part of a conversation to say we used to refer to it this way, but there are more nuanced ways of having the conversations about what medications should be used and what the risks are. With lactation, that has evolved a little bit more. And again, this is part of the conversation, but even with this list, there can be more ways of having more nuanced conversations as well. The way I look at it would really be summed up in this type of slide. And commonly, I end up with individuals who have mood disorders, bipolar disorders as well. And what you would say is, well, there was a time where we would talk about lamotrigine or lithium in these categories, C or D. But more recently, and what I often end up doing is having a conversation about what does this mean in terms of the scope of the pregnancy and the scope of the person's mood disorder overall. taking into account that lithium in the first trimester does have a higher chance of some adverse outcomes. But as people move forward into their pregnancy, it changes and can be much safer, especially in the late second trimester and the third trimester. And if there is a very uncontrolled bipolar disorder, it can be a helpful medication. And so that's where the nuance of the conversation starts. And then thinking through, again, like in lamotrigine, how is that helpful or has been helpful over time? Those types of conversations take multiple iterations, and if possible, there could be an opportunity for planning for how to use these medications safely. Within that, there are also medications for what I deal with commonly for opioid use disorder. Methadone and buprenorphine are commonly used for that type of treatment. Naltrexone is used more and more. However, there needs to be more evidence to show whether that can be truly used in terms of the induction process, because getting people onto, let's say, naltrexone from a fentanyl or other illicit opioids could be very difficult, and there hasn't been a proven way of getting that process started. However, with methadone and buprenorphine, there have been trials done, some of which were conducted at the Center for Addiction and Pregnancy, to show that they can be helpful in decreasing adverse perinatal outcomes and decreasing hospitalization time for the infant as well. For those who are unfamiliar, there are much larger swaths of information available through the SAMHSA websites that are up. And the one I would point out the most is the website that looks at addressing specific needs of women for treatment of substance use disorders. I feel like many on this call are already aware, but I would say within that, there are many tidbits that are brought up that are helpful and very pertinent to this talk. Part of that is screening, and I have a list of certain screens that are brought up in the website, but also some that I use on my own. I'm finding now that for substance use disorders, we are definitely thinking about the illicit substances, the opioids, the benzodiazepines, even amphetamines. But sometimes the more, I would say, common and commonly available substances are things that we need to think about more. Many people ask if an individual is smoking, but what I'm finding more is that nicotine use, especially vaping, is considered separate from smoking. And that's something there needs to be a focused effort to account for. And also THC in the many forms in which it can be ingested or used needs to be brought up, because it can last in the system longer, going back to the physiology of how that volume of distribution and the protein binding, things of that nature, it can last in the system for a long period of time. Of course, depression is something that we need to look out for, postpartum depression especially. What I would note and what I have seen is that it's important to look for other mood disorders beyond the depression itself. I remember my first patient that I worked with, this is over almost 20 years ago, I hate to say, but she was referred to me after her postpartum depression, was treated initially for Zoloft, and came in with bright blonde hair and very much manic. And they hadn't done a full history of what her ups and downs were for her mood. So I say now it's very important to screen for the different mood disorders, in addition to depression. And the DSM-5 level 1 screener I found to be helpful to see a bigger picture of what's going on. Of course, trauma is very important as well, not just with interpersonal violence, but any type of PTSD symptoms that may be coming up, and other behavioral health disorders, even sexual disorders that may be present, or eating disorders. So getting that wide swath is important, because those don't disappear during the pregnancy themselves. And then planning, as I mentioned, is very important, if possible. And I know that may not always be plausible with certain situations, but if possible, it's important to see if there's any plans for counseling in terms of breastfeeding, appropriate team members that you might need to bring in, other non-pharmacological interventions that might be available. With chronic pain especially, it may be that you might need additional help from occupational therapy or other spaces to deal with things that medication either aren't appropriate for or might be unsafe during the perinatal period. And it's important to discuss the risks pragmatically. I've had at times people who have been on ADHD medications, and you don't always remove everything, because it may not be pragmatic depending on when they're showing up in their pregnancy to stop everything right away. And then the same goes with nicotine. I always see individuals coming in smoking, but we have to have a conversation as to what's reasonable and what's a comfortable pace to make any changes, because if it causes stress on the mother, then it would also cause stress on the baby as well. So we need to have a collaborative and hopefully multidisciplinary approach. I meet every week with my OBGYN colleagues and my pediatric colleagues on the postpartum side to ensure there's a good workflow with prenatal visits, postpartum visits, and that eventually there would be a primary care doctor to work with this individual long-term postpartum because it's continuing. And as I mentioned earlier, breastfeeding should almost always be encouraged because of the benefits, but there are situations with pragmatic conversations where it may not be possible. But all of this planning is part of the standard documentation that's out there. Something I just wanted to make sure that's part of the conversation. Not screening per se, but something that's important and should be discussed with each individual. Beyond that, there's also the ethics of the conversation. And I bring this up in terms of ethically saying, what should we be doing for the individuals coming in for treatment? Just to review the biomedical ethical principles that I work with mainly, and there are multiple versions of this, are non-malfeasance, do no harm, beneficence, which is do good, and then autonomy, a person's ability to choose what they would like to do, and then justice, which I'll define in an alternate sense in a couple of slides. Postpartum care, I think, is a very clear marker of this type of ethical principle set in that we need to make sure that during the most vulnerable time, when a person is prone to relapse, we have the right care in place. The majority of maternal deaths, as many know, are related to substance use disorder relapse or occurrence in the postpartum period, mostly occurring in the first 60 days. One thing that we did in Maryland, and this is beyond just screening, but also advocacy, is we advocated for the expansion of Maryland Medicaid to 1 year postpartum. A point in time, we had to discharge a lot of our individuals right after they gave birth. And this, we found, did lead to a surge in relapse and adverse outcomes. And so part of our advocacy was to talk with legislatures and see what was possible in terms of Medicaid. And we found that to be helpful, and that's expanded our engagement with individuals. Beyond that, social support, I think, is something that cannot be underplayed. This is information from a study that we were able to publish last year, where we talked to the women in treatment with us during their perinatal period and asked them, do you have drug-free support? And support that would be helpful in your recovery, that you would want to engage in your recovery process. Not only did they say they had those drug-free adults, 4.4 was the mean number of individuals, but 80% of the women in treatment said that they would be willing to activate those individuals in treatment and increase that social support. And that's important because for most behavioral disorders, social support is known to be the best predictor of success. So that is an opportunity that others can be using in their screening process and their conversations with their individuals to say, do you have other people that we can rely on and bring into the situation to make it lighter? Not to say that the healthcare practitioners aren't important, but social support can be very important as well. In other places, it's also important to understand where the information is going, and privacy is a big portion of that, in that we know with electronic medical records, information can get everywhere. So it's also important to know who may be reading the records of the person who's coming in for treatment. Sometimes there can be interpersonal violence and someone can have access to a chart, and you might want to know that. The other part of it is knowing what the individual coming in for treatment wants to do with their records is an important conversation because there are laws that are changing. Really, in this sense, 42 CFR, which is the privacy of substance use disorder treatment records, it formally has changed at the beginning of this year, but the ramifications and the legality of it really kicks in next year to say that folks will be penalized if information gets out that isn't properly tagged or consented. At some points, it has been shown that the directors of different programs feel that this 42 CFR law in the past had been a barrier to communication for information sharing, and there needed to be an update of the regulations. However, now with things changing over the next few months, it'll be important to understand what do the patients and the individuals coming in for treatment want to do with their records. What we found earlier this year, and we were able to get this published, is that especially individuals and women who reported healthcare individuals in the emergency and perinatal care context, they felt that they were treated differently, negatively about their substance use disorder history. So learning about the medical and substance use history is important, but also any stigma they may have been encountered with in the past. is important so you understand how to engage them best and understand, make sure they understand what you're putting in their record so you can build that trust. And also building awareness with them of how the records would be shared so you can downplay any concern that things might go to CPS or other places that might have negative outcomes for them in the process. This is all part of a bigger picture of structural competency, which is a different term, a term that's been around for a while, but really saying a term that the organization has the ability to recognize and respond to the larger social context with a reflexive humility and community engagement. And there are two ends of that, and saying that sometimes the organizations need to really have a deeper conversation, and that's the healthcare practitioner or the administrators, a deeper conversation with the individuals coming in for treatment so you can have an understanding of their stigma, their behavioral health, their mood, all of those things that are going into place, but then making sure that they understand it in the context of where they're going to be. And I think that's where a lot of things will shift over time. And we've already seen that that shift is needed because even prior to the pandemic, there was a surge, or really a growth in neonatal abstinence syndrome. Rose by 413%, rose by 335%, even though the number of buprenorphine prescriptions rose just about as high. So it's all to show that the prescriptions and the medication alone isn't what's going to solve this. I think that's a big part of it. However, we need to understand the social context as to how we can increase the support and the long-term outcomes. Part of that I show here through a schematic that we have at the Johns Hopkins Urban Health Institute. I'm the associate director of that institute, and we try to build partnerships in different ways that can lead to a healthier environment with shared decision-making, communication, and values of mutual respect so we can benefit from the community and the academic combination to get more for the individuals that are coming in for treatment. One big example of that is the Center for Addiction and Pregnancy and what we've been able to do over the past few years. There is a community-based organization called Helping Up Mission in Baltimore that prior to 2023 actually didn't house women at all. They had been a men's-only shelter. And in 2023, they stood up this building. This is the actual picture of the front of the building that now houses up to 250 individuals, 200 women at max, and 50 children. Even in the past 2 years, it's now up to about 125 women and 30 children and has capacity to grow even more and fill that up. What they did is reached out to us during the pandemic and said, we need someone to help with the behavioral health treatment. So that's where the Center for Addiction and Pregnancy, which is on the Bayview campus about 5 miles east of this building, said, let's try something out where individuals either come up or are engaged with our counseling staff through telehealth, or driven up by the staff at Helping Up Mission for in-person medications and other treatments. And therefore, they are able to stay in this building for up to a year. I think that this is something that has been very important because it's led to a higher rate of engagement and kept women around much longer than it was when the housing was wherever they could find it in the city. So it's an opportunity to think about that partnership and that community academic collaboration, but something that could also lead to more social support, which I said earlier is something that could be important. But we find that people at the beginning of the process, when they call us, say, I need a place to stay, and this is an option. It's not the only place where we take people from, but screening for their housing and other behavioral social determinants of health is really important. And having a place like this at Helping Up Mission can be a way to solve that as well. So in summary, and again, I mentioned many portions of this talk could be 2 hours in and of itself. There can be a complex presentation of how things go during perinatal treatment. Treatment is dynamic, whether it's the physiology, the medication metabolism, different social pieces as well. And those influences are something you need to screen for and be aware of. Whether it's the depression, whether it's another mood disorder, all of those over time, it's important to get a deep sense of. The diet is very important within that, but it's also important to get a feel for the broader social support so that you can do, or the best pieces can be put in place for the success of the individual. So I'll leave the references here for people to see, and I appreciate the time here today.
Thank you so much for that presentation. And so now I want to open it up to the participants who are here on this ECHO call. Are there any questions from the learning community? I saw a few, or maybe one in the chat, and want to allow others to unmute their mics and ask those directly.
I didn't have a question, but I had written in, I'm Joy, part of the hub. I had written a few things because I can't help myself. I loved the concept of like, how does this treatment work for this woman? You know, it's not one size fits all. Where is she at? Pregnancy, antepartum, postpartum. It's just a really vulnerable time. That's the other point I had written down, that pregnancy and postpartum, all the way up to a year or more, are just really vulnerable. Tons of hormonal changes, support shifts, sleep shifts, just a really high time for relapse. So I just was very much feeling connected with that concept of like, we can put a plan out, but what are our pillars guiding us? We have to listen to how it's going to land on the patient. Oh, now some questions popped up.
Oh yeah, and I'll throw a wrinkle out there. It's not lost on me that I'm often one of the few male providers they will see in this conversation. So there are often different things you have to broach as well. That's not just if it's a woman provider. It could be any type of topic. So it's important to know those pillars and say, are there things that I'm missing that are important to you that should be brought into the conversation as well? But thanks, Joy, for your comments.
Yeah.
We have a question in the chat from Francis Carrillo. Francis, if you have the microphone, would you like to unmute and ask your question aloud?
Even if not, I think I scrolled to it there. I'll read it out for him if the mic is hard to get to. The question was, where did the funding for the Women and Children Shelter come from, and what supported the switch from only serving men? The easier one is what supported the switch. It's hard to be in Baltimore and not see other individuals who are in need and not see that need and go with that need being unaddressed. It was something we also said at the beginning of our partnership when we started working with them and the men, to say we need to be more balanced with who we're treating. And so we pushed for that as Hopkins an organization. Helping a Mission is independent of Johns Hopkins, and they did a lot of capital campaigning on their own. So I think philanthropy was a large part of that as well. And so those are the big two things. There is a documentary out there about it that escapes me at the name at this moment, but it is something that they had to do a lot of fundraising for.
Hey, Emily here, one of the hub members. So I'm a family nurse practitioner, and I find that there are new screening guidelines and tools. I feel like every time I turn around, and it's a little bit hard to keep up. And so practically speaking, do you have like your top 5 favorite go-to screening tools that you really find high yield, that are easy to use, that you would recommend to the group?
High yield and easy to use. Those are often hard to find at the same time. I'm biased in that we have Epic, and Epic does some of that correlation of data. I like the brief addiction monitor and the DSM-5 level 1 screener because it gives me that snapshot. And I tell all my individuals coming in the door, I'm Bob Ross. I'm painting a painting, and this first session is just going to be the base layer. And those two tools just give me a shot of, all right, are you smoking too much? Are you having this issue? So it's quick and I can see things quickly, but I have Epic that gives me the data quickly. I think from there, you have to figure out what's easiest for you. Even the session rating scale would be helpful for people to say, are we aligned? Are we on track? Because often for substance use and perinatal care, that alignment's important to keep the person coming back for subsequent visits. So if I didn't have Epic, I'd probably be on that level of, how good or connected are we, and an open statement for are there things that I'm missing. But that DSM-5 seems to be good, but it's already 12 years old, so I know in time it's going to go away.
Thank everyone for their comments and their questions, and continue to encourage you to drop those into the chat as we move to the case presentation for today. And so I'd like to welcome Montrese Green, who's going to present our case. If you would please unmute your microphone and walk us through the case. Having just a little difficulty with your audio.
Okay, are you able to hear me?
Yes, we can hear you now. Thank you.
Okay, good afternoon. My patient that I encountered is a 32-year-old female, white Hispanic. She arrived at the hospital by EMS after being found on the sidewalk. She reported recently finding out she was pregnant and had no prenatal care. She had a positive toxicology screen upon arrival. Shortly after arrival, she expressed feeling a need to push, and she subsequently delivered a twin determined to be 24 weeks. The twin passed away in the NICU the following day. Patient did visit in the NICU. Although patient appeared to be of average intellectual functioning, she did not appear to have a reasonable understanding of the severity of baby's condition, which was severe prematurity. Following the passing of twin B, patient made delusional statements. She verbalized still being pregnant. She reported caring for the babies with regard to feeding and bathing during her stay. We had concern that she was also just having a possible denial of the baby's passing. Patient did finally accept the deaths of babies just prior to her death. Prior to delivery of the twins, her reported OB history was 6 living children and a prior live with their fathers per patient report. She also reported to be studying to be a therapist, as well as owning her own charter school along with her brother. The patient had no visitors during admission, and she reported to be living with a family friend. During her her 48-hour inpatient stay, her toxicology screen was positive for amphetamines, which she denied any substance use history or use. She was evaluated by inpatient psychiatry team, was diagnosed with stimulant use disorder, schizoaffective disorder, bipolar type, and ruled out for postpartum psychosis. During her stay, she was offered supportive and grief therapy through myself and also the perinatal palliative care team. She reported not being on medication. She also reported no mental health history, but did make a comment that she had been prescribed medication in the past for a personality disorder. During her stay, she was recommended to start Lexapro and Abilify. She was also offered voluntary inpatient psychiatric hospitalization, which she declined. Patient did not meet criteria for emergency detention, and she subsequently left. And I believe a postpartum depression screen follow-up was recommended and scheduled for her, but I'm not sure if she followed up with that appointment or not. And during her stay, she was somewhat cooperative during some interviews. We were not able to gain a lot of information from her at times. And so we just had some difficulty as far as addressing her needs. And I just felt that it was a good case for presentation because I would love to hear what recommendations would have been helpful for her during her stay during this traumatic time for her. Thank you.
Thank you for that overview. And so now I'd like to open the floor to our participants for questions, for insights from our learners. Is there any information that you would like to know, additional information that might not have been covered during this case overview? Do you have any questions about the patient or this particular case? And I encourage you to unmute your mics and ask those questions or offer those comments aloud.
Hey, hi, one of the hub members. Last name is Alog. Great case. I do have a question as I hear, and maybe it was me only with the in and out, but the schizoaffective disorder, do we have any idea when that was diagnosed? Because it sounds like she's been using substances for like a while, the stimulant use disorder diagnosis, and sounds like she was also positive for that on a drug screen. So do we know like she had the schizoaffective even prior to being diagnosed with stimulant use, or she started using prior, or did the diagnosis came about while she was using the illicit drug, which is the amphetamines?
I know that she didn't give a lot of background information as far as her mental health history, but she did mention some things during her evaluation with the inpatient psychiatry team. So I'm not sure if it came by history or from whatever they were able to gain while she was here.
Got it. The only reason I kind of ask is because if someone's using stimulants, as we all know, there's always a reason to why they're using. So are they kind of self-medicating the symptoms for the mental health, or is there something else going on? And why she was using the stimulants to give energy? I wonder the Celexa and the Abilify, like was it a sleep concern at night, which was kind of not letting her have a lot of energy in the morning when she would wake up? So I wonder with that combination, like what were they trying to target? I mean, of course, for schizoaffective, you can use Abilify. I hear Celexa, I have kind of mixed thoughts on that, but I wonder like what was going on, if at all, like in terms of treatment, what were they hoping for when they were targeting the medications?
Right. I'm not.
Right. In general, sure. But in general, like, a lot of the patient population that we do happen to see here, at least for the underserved patient population, is typically they do really well if you kind of ask them what their main concern is for using it, and they would probably say low energy or I'm not sleeping well at night. And I think enough all of us, as we know, targeting those symptoms specifically is really important. So, I mean, some patients might really do well on Wellbutrin. If you have bad anxiety, you might want to consider some other form like Statera, which is a non-stimulant ADHD medication as well. And maybe not, maybe it's just a sleep apnea concern. How you sleep at night is also very important, which could also interfere with your functioning in the morning. So I think that might just be very helpful to know. Because it's a big loss if she lost like 2 of the twins together, even though she had 6 in the past. That is still a pretty big loss for her.
Yes, it's a very, very traumatic experience. Thank you.
Thank you, Dr. Alog. Jasmine has dropped the case presenter questions for the learning community into the chat. So the first one, what, if any, other therapeutic interventions could have been utilized to better support this patient? And if the patient did engage in therapy following discharge, what modality would be recommended for best outcomes, considering the patient's background? I continue to encourage our participants and our learners to drop your comments or questions into the chat, but also to unmute your mic and ask those and offer those aloud.
I'll put a thought out there. I see it in the chat. But I think contingency management is important to consider. I think it would be important to understand what would be a relevant reinforcer for the person who came in for treatment. Not everyone is going to be able to give out a $5 gift card. We actually were disallowed from doing that about 10 years ago. So if you were going to use contingency management, knowing what would be helpful for her, what would be reinforcing and keep her coming back, that would be important from my perspective.
Can I ask one other question about the case? I think it's two, and Dr. Humphreys might want to, I think she'll agree, we talked about this earlier. I wondered if was there a reason why she went home so quickly at 48 hours after delivering? It sounds like roadside with one twin and then another demise a day later. So I just wondered why she went home so early. And I wondered if they tried to contact if they, being anyone on her care team and patient, tried to contact the family, brother, anyone that she lived with to get a little more perspective on where she actually been living, what her patterns are.
Yes, inpatient psychiatry.
We're cutting out.
And then at some point,
Hi,
sorry.
I'm so sorry to interrupt you. We're still having a few problems with your audio, and you're
okay.
in and out.
Okay, can you hear me clearly now?
We can hear you clearly now, yes.
Okay. Inpatient psychiatry did engage the family or attempt to engage the family. They were able to maybe reach one family member. And then at some point, patient she voiced that she did not want her family members contacted. Patient did make a decision to leave AMA. So
Okay.
that's the reason why she left so quickly. And then I did fail to mention that we did offer LCD.
We're cut out. Sorry,
denied. Oh, we offered LCDC consult for the patient while she was here, and she declined, and also denied substance use history altogether.
Got it. Yeah, so that's a really good point for the learners and for myself, that it wasn't a discharge at 48 hours, that it was an AMA. That's really different. That leads me to want to, and I don't know what this acronym is in Texas or other places where you all are living, but if this was my case, I would want to do an application for persistently and acutely disabled. You know, if she didn't meet criteria to be admitted to like a level 1, and she didn't want to go on her own, in Arizona, there's sort of like a third option of a behavioral health team calling or visiting the home to try to re-engage in services. So just because she left. Yeah.
Right.
I think, Montrese, to answer your initial question, like which modality and things, it sounds like I don't have an answer for that because she's denying everything, right? And so it's hard for us to get a sense on what the best modality of treatment is when we don't really know what's going on because she's not giving us a lot of information. When I have found that I'm kind of stuck in that situation where I don't know what's going on with the patient, so I don't even know how to treat, sometimes I just simply ask them, like, what would be most helpful for you right now? I've been shocked at what some patients have told me to that question. It's gotten me in trouble a few times, but sometimes just seeing what her priority is, what is most important to her, and starting there and building from that. It might be housing. I don't know. It might be re-engaging with other family members. I don't know, but trying to find what the patient's priorities are and starting to build that. And that helps build rapport and trust. And then you can go forth. So that would be my only recommendation for the next patient you encounter like this.
I appreciate that. Thank you.
I actually, just an example, one patient I asked this to, he was a homeless individual that I had a really hard time engaging with, and was having a really difficult time figuring out what to do. And I asked him that, and he got really quiet. And then his answer was he wanted someone to play chess with him. He said he loved playing chess and no one had played with him in years. And we played chess together for about an hour one day. After that, everything changed. It just opened the door. So just finding what that patient wants is helpful.
Thank you.
You, Dr. Humphrey. We have another comment from Harmony Smith in the chat. Harmony, I'd like to give you the opportunity to make your comment and elaborate aloud, if you'd like. That's not a problem at all. So Harmony says, I would start with person-centered supportive counseling to establish a good rapport. Then I would spend a lot of time focusing on stabilization and emotional regulation skills, keeping patient autonomy at the forefront and focusing on safety and regulation. Person-centered, maybe DBT skills and somatic strategies. Dr. Alag, you have an additional comment as well?
I do. I just wanted to add to the point. I think it was great. Like, kind of offering monetary rewards to patients is not always possible, especially community or, underserved areas where we have our clinics and whatnot. I do think sometimes we do offer at our clinic kind of badges to patients, which, might matter, might not matter to some. And also, like, we haven't done this, but just kind of struck me the kind of patient of the month certificate, if that's important to some, or maybe access to recreational equipments. We are hoping to get one in future. We don't have one, but if there is an area around or something on those lines, if patient kind of likes it, might be an option. I think Dollar Tree kind of sounds like it's something which is within a reasonable reach for us, or I might also kind of go and bring a couple of coloring book activities and leave that in my clinic so that, they can be given out to the patients for coloring if they're doing so phenomenal. But typically, we do actually in our clinic, we do end up giving up $25 gift card, Walmart gift card to our patients if they've been doing really well for about 8 to 12 weeks. And then I think after it's about a year or something, and many of our patients have responded really well to that. So I want to share it out there.
And I want to just add to Dr. Alag's comments, reach out to your institutions or nearby institutions. There's often a lot of outreach programs that have different swag items that maybe they could send you an abundance of, or just items that you could keep in your office and use as these reward items.
Or even making their travels a little bit easier. We don't have any funds, but I'll say I'll set up your ride for you right now. That's just a big incentive, at least in my area. And it kind of also says, I want to see you again. It says, we care about you coming back. So I know it seems really small, but just setting up their ride to come back is one thing I can offer. So maybe all of you can too. Ride is really big, yeah.
We have a few more minutes to spend on this case discussion, and so I encourage everyone to consider what's been offered already and consider what similar patients that you've had in your clinics or that you've heard of, and what treatments, interventions have been helpful and successful, and offer those into the chat or aloud.
Oh, someone wrote, has anyone thought about doula? Yeah, I would agree with you. And I bet a lot of you are shaking your heads that any sort of support, if it's postpartum doulas, if it's a postpartum depression support group or a helpline, a lot of those are free and available by phone, obviously.
Diane has written a comment into the chat as well. There's so much guilt and shame with youth while pregnant. I really do my best to let them know they're not bad people because they feel the worth. Working with pregnant women and giving birth and having baby taken, guilt and shame has been present most of the time. That's a great point. Thank you.
I would also encourage, I was the one that wrote the doula comment in the chat, and I know you responded and said postpartum doula. There's doulas all across the spectrum of birth, and so I would definitely encourage doula support in early pregnancy if possible, but definitely throughout pregnancy and definitely postpartum. The earlier we can get that emotional support to pregnant moms, the better. They can build that relationship and that bond, and they can feel safe to share a lot of the things that they may not feel comfortable sharing with the provider, right away. And then as a doula, I kind of help my clients reframe why they're afraid to say these things so they can get help sooner. So definitely pushing for that support and maybe even providing some resources for that. Sometimes they're free, sometimes they're not. Yes, there are grants and things like that. I always also refer warm transfers. And so if you're transferring to another provider, making it a warm transfer and not a cold one, and maybe having that conversation with the provider you're going to refer them to with your client, so that they don't feel like it's something else they have to do on their own. Definitely making warm transfers can help them keep their team solid.
Thank you, Jasmine, for that point, especially about the warm transfer. It's such a small act, but such an impactful one. Abigail dropped a comment, and Dr. Subrin did as well, about Willow Wish Doula and San Antonio Birth Doulas. And Kelsey's dropped the PSI helpline into the chat as well. Montrese, is there anything else that you specifically that you would like, any other suggestions that you're wanting or looking for that haven't been addressed yet or haven't been offered yet?
I feel that all that was offered was very helpful. I wish we just had more time with the patient. You know, she came in a distraught kind of pregnant, and then with the delivery of twins. So we didn't have a lot of time. We didn't have a lot of history with the patient. So I wish we had more time to establish rapport and have some of these supports in place for her, you know, for possible better outcomes for her.
This was a really complex case. I'm so glad you brought it to the meeting today, and it's so wonderful that 106 people are sitting here, because if this woman, you know, doesn't come back to the hospital or the clinic, but lands at your soup kitchen or lands at your resource day, that, you know, you'll have all these things in the back of your mind. That's really the power of this type of learning, is she might not end up at a traditional health facility, but maybe something we've learned in this discussion will help her wherever she lands.
Right.
Yeah. I wish she stayed longer too. That's happened to me many heartbreaking times when I was inpatient. Yeah.
Pretty heartbreaking, I think, for, you know, all the teams involved.
Yeah, of course.
A great conversation, and I'll continue to allow you to drop your comments and questions into the chat. And since we have just a brief moment of before we move on to our announcements, I do want to allow our other hub team member, Dr. Alog, to introduce herself. Dr. Alog.
Hey everyone. I don't know how to go about it, but yeah, I'm one of the triple board certified addiction psychiatrists. So I do have my certifications in general psychiatry, addiction psychiatry. A lot of my colleagues and my trainees think I'm addiction medicine. I'm actually addiction psychiatry trained, which I think is very beneficial for our patient population. I'm also obesity medicine trained, so I kind of like the holistic approach for my patients. I am one of the assistant professors at Department of Psychiatry at Texas Tech University Health Sciences Center. Also happen to be the medical director for the addiction services at our department. And I think one of the most important things for me is what I'm passionate about is the opioid treatment program that I do for StarCare. I'm kind of only employed by Texas Tech, but I also go and work at StarCare, which is the one of the community places in Lubbock, which is, I think it is amazing for our underserved population. I do the methadone and Suboxone there in that clinic, and also happen to be the medical director for that clinic. So that is pretty much all that I do, and I absolutely am very passionate about this patient population, specifically addiction, mental health, females, and we at this point we actually have 2 pregnant females who have opioid use disorder we're treating in our clinic. So, of course, pregnant females and postpartum, taking care of them.
Thank you, Dr. Alag, for your work with your patients and for being on our hub team as well. And so we will now move to some brief announcements to wrap up this session. We thank everyone for being a part of this ECHO. We thank you, Dr. Antoine, for being our presenter today. We will continue to take comments and questions in the chat. But just to receive credit for today's session, participants must have an active account with the Texas Tech University Health Sciences Center Office of Accredited Interprofessional Continuing Medical Education Office. You can create an account by clicking on the link that's been provided in the chat or on the instructions on how to receive credit document that's been posted to the Content tab on iEcho. Participants are eligible to receive up to 1 hour of credit based on the duration of your participation, and those increments are listed below. For specific questions about CME credits, please email or call the TTU HSC CME office. And let us know how we're doing by completing our evaluation. You can scan the QR code, which is on the screen, or you can click on the link that's in the chat. The evaluation will be available until 11:59 p.m. on June 17th. If you already have your account set up with the TTU HSC CME office, you can use the text in feature with the code 39650. The text code is only available until 11:59 p.m. today. Please remember that in order to receive CME credits, participants must have that My Portal account set up already. Do you have a difficult case that you or your team have encountered? Well, CSTAT offers you the opportunity to present any challenges your organization is encountering and to receive feedback from our hub of experts and the broader learning community. There's no need to prepare a formal presentation. You'll be provided a case form to fill out, which will assist with your case presentation. Please email us at cstat@uthscsa.edu. The Center for Substance Use Training and Telementoring offers technical assistance for various substance use disorder needs and topics via our team of experts. To request technical assistance, please complete an online request form at c-stat.uthscsa.edu/contact-us, and we'll be pleased to help you. That link has been dropped into the chat as well. And with that, I'm going to pass this presentation on to Jen Erdigy with the PeriPan program, who has a few announcements for everyone.
Hi, thanks, Brenda. I'm just going to provide a very brief overview of the Texas Perinatal Psychiatry Access Network, known as PeriPan, which is designed for clinicians who see pregnant and postpartum women. PeriPan was created to address the maternal mental health crisis. Mental health conditions are the most common complications of pregnancy after childbirth. They affect 1 in 5 perinatal women and ranking among the leading causes of pregnancy-related deaths. A lack of access to care and provider shortages further compound this problem. And PeriPan has 4 major components, as you can see on this slide. We provide clinical guidance to help you with a single patient case or enhance your mental health care and practice as a whole. Next slide, please. PeriPan is anchored by 12 regional medical schools and health-related institutions across Texas, as you can see on the map. Signing up is easy, and you'll reach a mental health expert by phone and can consult with a reproductive psychiatrist within 30 minutes or at a callback time that you choose. Anyone in your office can call or text to start a consult or request, but each region does have their own unique texting number, which will be provided to you at sign up. You can call the number on the screen to enroll. And then next slide will be real brief. We would love for you to join our PeriPan webinar series, which is held on the 3rd Tuesday of each month. These sessions complement the ECHO series, offering a deeper insight into perinatal mental health. On the screen, you do see a list of upcoming topics and dates. Be sure to register and stay informed. You can connect with experts and expand your knowledge. We do look forward to seeing you there. And then the last slide should be the list of upcoming lunchtime maternal mental health echoes, which are held on the 1st Tuesday of the month. We do invite you to join us in the future sessions to continue learning about these important topics and engage in meaningful discussions that support perinatal mental health. And then back to you, Brenda. Thank you.
Hi, everyone, and thanks, Jen, for those announcements. I see lots of comments about the code. If you would please wait until about 1:05 p.m. to enter that code. It usually is active right after the session ends, and I'll alert the CME office that we are having those technical issues. If the issue persists, please email cme@ttuhse.edu. And so now I'd like to move on to our final kind of closing remarks and recommendations from Dr. Humphrey.
Yeah, so thank you so much, Dr. Antoine and Montrese. We appreciate all of the great content y'all brought us. To just summarize, we need multidisciplinary approaches. Medication alone won't solve a lot of these issues. These are complex. Planning is important. Postpartum care is a vulnerable time, and good social support is crucial. And I think that we heard that in the didactic portion, but also all felt that in that case presentation. Overall, this is complex and there are multifactorial influences, and we need that broad net of support for these patients. And that might involve the doula groups, or getting other family members involved, or other types of support. But since it is so complex, we need a wide net to help support these patients in this really vulnerable time.
Thank you so much, Dr. Humphrey, and thank all of you for joining today's Maternal Health Echo. We extend our appreciation to Dr. Antoine and to Montrese Green for their parts in today's presentation as well. As a reminder, to earn CME credits, please complete the evaluation using the link in the chat. If you have a case or scenario that you'd like to share, please consider filling out a case presentation form, and we look forward to seeing everyone at our next session on Tuesday, July 1st at 12 p.m. Central Standard Time. Have a great rest of your day, everyone. Bye-bye.